what are the trends with ABSSSI and the risk factors or the drivers of it? No question, we've seen a huge increase in skin infections, both in the community, in the emergency department, and admissions related to skin infections over the past 15 to 20 years. I think there were two main drivers for that. One is that the bacteria that cause that, particularly Staph aureus, is the type of clones of Staph aureus. So one clone in particular that's known as USA 300 that circulates now through the communities and hospitals in the United States is known to be more virulent than other Staph aureus that we used to see in the past. In other words, many people are colonized. On average, about a third of adults are colonized with this bacteria, but the likelihood of infection if you are colonized with this particular bacteria is higher. So that's one driver of the increased frequency of those infections. And the other is obviously the fact that we see people who get older, life expectancy is going up, more people have diabetes and other risk factors for skin infections, overweight, sedentary lifestyle, and become more vulnerable to develop skin infections. And so both on the treatment side and the risk factors for the infection, we see an increase. And I think the expectation is that skin infections will continue to increase with the aging population. So what are the standard protocols for treating those infections and challenges? Standard protocols involve antibiotic use and follow-up. And drainage of an abscess. The skin infections that we see typically are divided into redness, painful redness, infected redness, which is usually cellulitis or erysipelas, or an abscess. And those abscesses need to be drained, and with or without antibiotics, depending on their size, or wounds that got infected, for example, trauma wounds or surgical wounds that get infected. Of course, the main step is choosing the right antibiotic, because those infections are almost always are caused by gram-positive bacteria, such as strep and staph. These are the bacteria that you want to cover. And because MRSA, which is the more antibiotic-resistant variant of Staph aureus, is now so prevalent everywhere, including communities, you need to make sure that, at least in patients who are sick, you want to cover MRSA as well. One of the challenges is that for many of the patients, we don't actually have any guidance coming from the microlab, because there's no cultures when you have cellulitis or erysipelas, and you have to treat based on your understanding of what type of pathogens cause this and what is their susceptibility. Challenges are the resistance, of course. It was much easier to treat skin infections 10, 20 years ago, particularly in the community, because they would be responsive to many of our narrow spectrum best antibiotics like cephalosporins and penicillins like oxazolone, dicloxazolone, and Caflex and antibiotics like that, which are not just very active but also very safe. And with increasing resistance, we have lost most of the antibiotics that could be used for skin infections, and the ones that we have are not as good as the ones that we didn't have. So you have two issues here. One is that you may give a patient an antibiotic for which the bacteria that's causing his infection is resistant to, and even if the bacteria is susceptible, the response may not be as good as it used to be in the past. And this is, of course, a major challenge. Another challenge is that many people don't have health insurance, and skin infections are seen very often, and particularly seen in some populations more often than other populations, like people with IV drug use and so forth. And some of those people don't have good insurance, and so they don't have good access to care, and very often they find themselves in the emergency department as their first stop for care, and that has been a major challenge as well.